Thank you. All right, well, I'm so excited to be here today. What a great conference. I just want to give a shout out to Dr. Miller. Here's some things I took from his lecture. He tells people with diabetes, I am there for you. It's not about the data. You can do this. I am here to help you. You are the mechanic who knows your body best. Wow, that's the kind of provider I want to see. How about you? Like, yeah, that's my person. Well, I come from Chico, California. Does anybody know where Chico is? Yeah, it's a little town up northern California. It's pretty rural. We grow nuts there. So we grow almonds, pistachios. But if you go to Chico, don't ask for almonds because they will know you are not a local. Because I moved there 26 years ago. So they don't call it an almond, they call it an almond. So I'm like, why do you call almonds almonds? And they go, well, to get the almond out of the tree, you have to knock the L out of it. Almonds. I don't know. Chico, where the nuts are from, that's what their motto is. So I'm excited to be here. It's so beautiful. I've been enjoying this conference, and I'm excited to share this information with you. And you all got one of our diabetes medication pocket cards in your folder, so happy to share that with all of you. What am I going to talk about today? Well, we're going to look at the different phases of diabetes from type 3 and beyond. The field of diabetes is growing so much. I'm so excited about this new classification of prediabetes that Dr. Miller covered because it really brings attention to addressing prediabetes early on. So I'm thrilled about that. I have no conflict of interest to describe, and today we're going to go beyond type 1 and type 2. I was telling someone, yeah, I'm doing a lecture that talks about what is beyond type 1 and type 2 diabetes. And they're like, really? There's other types? I'm like, oh yeah. And it's an expanding field. So what we're going to talk about today is hypercortisolism, LADA. Have you all heard of LADA? Latent autoimmune diabetes in adults. We're going to talk about diabetes type 3C, diabetes type 3, and diabetes type 5. And there's a whole other category called MODY, which I'm not going to address today because I have 45 minutes. So I'm going to talk about the most common variations we might encounter. Now, Dr. Miller was talking about the ominous octet, how he describes to people when he meets with them, like the 8 defects that are associated with diabetes. Well, I have exciting news for you, and I'm thrilled to talk about this. It went up from the ominous octet, and this is Dr. DeFranzo's work, who's like a famous researcher in the diabetes scientific community. Anyways, it went up to the noxious 9. How many of you have heard about this? Okay, so this is exciting. This is like the first movement in 20 years in our understanding of the pathophysiology and the defects associated with type 2 diabetes. So the first thing when we think about what's going on with type 2 diabetes, why do people have hyperglycemia? Well, one of the major factors is their pancreas. So when you're born, this is what your pancreas looks like. You have a full array of beta cells. But because of genetics and environment and social drivers of health, we all know about social drivers of health from that great lecture yesterday, as we get older, over time, that diabetes might express itself. So when diabetes expresses itself, we lose these beta cells, and our pancreas no longer appears like this. Wait, how big is your pancreas, by the way? Is it this big? No, like you would not be able to get your pants on in the morning if it was this big. It's like 2 fingers. But by the time a person has diabetes, their pancreas starts looking like this. About 20% of the beta cells that were originally there are remaining. Pre-diabetes, 50%. So without those beta cells to release insulin, blood glucose levels rise, and we've heard about that already. So the pancreas is really struggling to make enough insulin, and then we have the liver. I call the liver the party animal of the body because the liver stores glycogen, and glycogen is an important storage fuel for our body. So when we're not eating, when we're fasting, the liver releases glycogen to give us some fuel. Have you heard people with type 2 diabetes say, oh man, I don't know why my blood glucose is so high in the morning. I didn't eat anything past 9 o'clock last night. Whose fault is that, by the way? It's the liver's fault. I really blame a lot of stuff on organs because the liver overnight, if it's not eating and there's not enough insulin to keep the liver in check, breaks down lots of glycogen, causing this morning fasting hyperglycemia. Okay, so what medication helps the liver calm down? Metformin, and also basal insulin is really important. And then we have increased lipolysis. You've all seen people with type 2 diabetes have high triglyceride levels. Why is that? There's not enough insulin in the body to help store those free fatty acids and fats. So the triglycerides just keep floating around in the blood, causing even more insulin resistance and increased lipolysis. Another big problem is I was very beta cell centric in my description of the pancreas, but there's also alpha cells on here. These alpha cells actually make glucagon. And what does glucagon do to blood glucose levels? It causes it to rise. Glucagon actually tells the liver to make more glucose. So the pancreas, which I would consider the ultimate glucose thermostat of our body, has two major issues when people have diabetes. The pancreas isn't making enough insulin, so it can't store energy. Plus, the pancreas hypersecretes glucagon, telling the liver to break down glycogen. So the pancreas is causing all kinds of havoc, right, with people with diabetes. And then the muscles, 80% of your post-meal glucose is disposed of by the muscles. People with type 2 diabetes have insulin resistance, extreme insulin resistance at the muscle level. So that insulin binds to the muscle, but the muscle cell will not open up. So the glucose can't get into the muscle for storage. It just stays in the bloodstream. And that's why we see that postprandial hyperglycemia. And also, y'all know this, we have such great data to support that moving our body after eating is one of the most effective times to help get that blood glucose down. So if I ask people to, can you move more? And if you choose one time to move during the day, it's post-meal, because that's when the blood glucose levels rise. And I didn't use the E word. Did you all know that? I didn't say exercise. I said move more, because we really want to make it accessible for folks. Okay, what else is happening? We're having decrease in incretin effect. So people with diabetes make about 50% less of those gut hormones, and that's why the GLP, GIP combo therapies and GLP receptor agonists are so fantastic, because they're like hormone replacement therapy. We're giving our body back that gut hormone that it's lacking. And when people don't make enough gut hormone, of course they might feel more hungry, they have a lot of food noise, and they may not feel sated. What else is happening? So I'm at number 8, believe it or not. The kidneys. Usually the kidneys release glucose when the blood glucose is greater than 180, 200. But with diabetes, the kidneys keep circulating back that glucose and bringing it back into the body. But the latest thing, I'm on the noxious 9, finally I've made it to the 9th thing, has to do with the adrenal cortex. We're finding that people with diabetes, hard to treat diabetes, are experiencing hypercortisolism. Have y'all heard of that, hypercortisolism? Yeah, a little bit. It's just been coming out in the past few years, and this is work done by Dr. Buse and Dr. DiFranzo. So I'm so excited to talk to all of you about hypercortisolism, because I'm kind of nerdy, but I work at a clinic, and I have lots of folks who have trouble getting their blood glucose to goal. And now I have another reason, I have an idea of why we can't get those blood glucose and blood pressure levels down. Let's do a poll question together. So you're just going to yell out the best answer. AJ is a 52-year-old with type 2 diabetes. They present with worsening hyperglycemia despite taking 3 diabetes medications. AJ says, no matter what I do, I can't seem to get my blood glucose levels down. Which of the following clusters of physical findings would increase your suspicion that AJ is struggling with hypercortisolism? A, dorsocervical fat pad, wide purple striae and bruising. B, peripheral muscle hypertrophy, thick hair growth and flushed skin. C, weight loss, skin hyperpigmentation and generalized muscle wasting. Or D, pallor, brittle nails and spoon-shaped fingernails. So 52-year-old type 2 diabetes, they're on 3 diabetes medications, they have hypertension, we can't get their blood glucose or blood pressure down. Which do you think is a sign of hypercortisolism? I heard A. Would you all say A seems like the most reasonable answer? It is actually A. So let's talk about that. Because when you think about too much cortisol in the body, oftentimes we think about Cushing's syndrome. And so I think, Cushing's syndrome is extremely rare. We don't really find it in clinical practice. But what we're recognizing is that there's a nuance to this, that people with diabetes are experiencing higher levels of cortisol. So I asked AI to create a picture of the signs of hypercortisolism, And it did like it pretty well, but it misassigned the labels. So you'll see that some of the labels don't match the picture, but I thought it was kind of funny. So if you imagine people on steroids, what do you imagine in your mind? That people on long-term steroid therapy? Well, many times their BMI is below 25, but they carry extra weight here viscerally. Their extremities might be very lean, and they might have some muscle wasting. You might notice their skin is very fragile, lots of bruising. They might have those abdominal striae. So if we think about people, and this is especially in the transplant community, who are on chronic steroid therapy, we can imagine this in our mind. And now I thought about, wait, what about all the people I've served with diabetes who have that same body presentation? Maybe they are struggling with hypercortisolism. And from the research from Dr. DeFranzo, he said these 4 that I put in blue are the main indicators that maybe someone that you're working with resistant hyperglycemia. That means we put them on 3 medications, 4 medications, we still can't get that A1C down. Plus, they have resistant hypertension. They're on 2, 3 blood pressure meds. We can't get that blood pressure down. And then visceral adiposity, their fat migrates from the extremities to the viscera, to the abdomen, and bone loss and fractures. Those 4 clusters seem to be pretty good predictors of people with hypercortisolism. And of course, we'll see other manifestations, excessive hair growth, acne, and lots of folks with hypercortisolism, honestly, y'all, that they're not diagnosed, they're struggling with mental health issues. They're like, I don't feel right. There's something wrong with me. And then when we can diagnose them and address it, they're so relieved. So I want to talk about the CATALYST study. The CATALYST study was revealed at the American Diabetes Association in 2024, and there's 2 parts to it. But this was really the start of discovering this hypercortisolism. It was a very large study, a prospective trial going out into the future, and they were trying to see if hypercortisolism was contributing to difficult to control type 2 diabetes. And so what they did is they recruited 1,000 people, and these folks had A1Cs of 7.5 or greater. They were on 3 or more diabetes medications, or 2 or more hypertension medications, or 2 orals plus insulin. Like they were just folks that we were trying our best to get blood glucose down, but they really weren't responding. They used this very basic screening tool. It's called the dexamethasone suppression test. So they gave them 1 milligram of dexamethasone at night and then checked their cortisol levels in the morning. If their cortisol levels were greater than 1.8, they were defined as having elevated cortisol levels and were entered into the study. So this is a very small graphic, but I just wanted to inspire curiosity for you to read more about this and kind of think about in your setting. Do individuals in your service, in your care, have hypercortisolism that's not identified? But the main line is, what did they find? They found that 24% of people with diabetes, with hard-to-treat diabetes on 3 or more diabetes medications, had hypercortisolism. 24%. That was way higher than they thought it was going to be. But I want to share this other finding. The prevalence was 36% if they were on 3 or more antihypertensives. So how many antihypertensives they're on is also a predictor of hypercortisolism. Now, so then they found they had high cortisol levels and they don't have Cushing's disease. They sent them to an abdominal CT scan, and they found that about a third of them, 34%, had adrenal abnormalities, and those were treated. So the takeaway here is maybe we're under-detecting this. I want to just read who was at highest risk for hypercortisolism. And I also want to say that people with this condition are at higher risk for heart attack and stroke. So older age, BMI less than 25, a non-Hispanic folks, so white individuals are at higher risk if folks are on many diabetes medications, antihypertensive medications, or if they're taking, I can't see that. Hang on. Fibrates. Oh yeah, fibrates or analgesics. That's the other 2. So if they had any of those risks, if they had any of those medication-taking behaviors, they were at higher risk. So we can kind of keep that in mind. Okay, so now we've identified folks with hypercortisolism. What do we do? That's the next question. So this is an interesting intervention trial. This was part 2 of the study, and this was led by Dr. DeFranzo. And again, they used the highest quality methods, randomized double-blind, placebo-controlled intervention, and they had 136 participants with confirmed hypercortisolism. So some were given placebo, some were given mifepristone. Now, mifepristone, you might have think, oh, that's the drug that terminates pregnancy, because it is a progesterone antagonist. But for hypercortisolism, it's a cortisol antagonist. So it can be used in both settings. So the mifepristone, they started at 300 milligrams, and they escalated to 900 milligrams over 24 weeks, and they were trying to see, will this antagonist, which blocks the receptors from receiving the cortisol, show a difference in weight and blood pressure and A1C? The thing is, when you use a cortisol receptor antagonist, people feel like they don't have enough cortisol in their body. So they get this thing called glucocorticoid withdrawal. Even though there's plenty of cortisol floating around and more than they need, actually, it's not able to bind to the receptors. So people feel bad. They have nausea, vomiting, fatigue, and over 10% experienced hypokalemia and some peripheral edema. Some folks had some hypertension. So mifepristone requires careful monitoring. And this is kind of the question I'm thinking about a lot. If we discover hypercortisolism, how do we treat it in our community settings? You know, because, well, I'll talk about this more in a second. But what was the outcome of mifepristone? It significantly improved glycemic control and weight. Now, what are some of the next steps? We need broader screening, maybe some novel cortisol-targeted therapies, which are in the production line, and then long-term therapies, because hypercortisolism is a lifelong experience. Now, I just wanted to show you the results. This is not even treating the diabetes. This is just treating hypercortisolism. A1C dropped 1.5 versus 0.2 in the placebo group. They lost 10 pounds, but really incredible is they had 2 inches of waist loss. So their waistlines decreased by 2 inches, which is very significant. So that's a decrease in visceral adiposity. And the other thing they had to do is decrease their insulin dose, decrease their other diabetes meds, because they were getting hypoglycemia. Now, I do want to point out something about mifepristone. About 40% of people were not able to complete the full 24 weeks of mifepristone because they felt uncomfortable from the side effects, and many had hypokalemia. So again, that's where ongoing research is really required. So the question is, we could probably do the dexamethasone test, challenge, in office settings, but can we utilize mifepristone in clinical settings with the primary care provider team? Or what they said in the study is they really need to be surveilled by endocrine. Endocrine really we need to give an endocrine referral for treatment. But we all know that we have a shortage of endocrinologists in our communities. Like where I work, we really have to wait very long times to get people to see the endocrinologist. So this is a question that we will have to consider. But I think it's very exciting, this discovery of hypercortisolism leading to this resistant hypertension and hyperglycemia. And what's the ramifications for us in the field as diabetes advocates? It's just being aware of this. It's bringing up to the person living with diabetes if they can't get their blood glucose to target despite their best efforts. It's not your fault. Diabetes is not the individual's fault. No one can give themselves diabetes. And certainly, if they're doing everything they can to get their blood glucose down and it's still above target, maybe we can blame it on this hypercortisolism. Okay, I would like you all to stand up if you wouldn't mind, because the American Diabetes Association says we should stand up and move every half hour. So we need to follow their guidelines, right? So let's all, oh my gosh, you're all so happy to stand, I could see it. Okay, so I want to do some right, left, brain connectivity activities. So it's called the Macarena. Are y'all ready? So put your right hand, oh, I can see myself on the screen, okay, right. Left hand, flip over, right, left, behind your head, right, cross over, 1, 2, open up, 1, 2, and then what goes next? Da, 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 da. Okay, you guys ready to do it again? Da 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 Hey, Macarena. One more time. Da 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 da. Hey, Macarena. Okay, good job. Don't you feel better getting that right, left hemisphere talking to each other? All right. Man, we need to move. Our bodies are designed to move. Our bodies. Okay, let's do another one. You ready? So we got through one type of diabetes, hypercortisolism. Let's take a look at this person, 72 years old. A1C 3 months before was 6.2, and then 3 months later, it's 13.9. What the hee-haw? What kind of diabetes is that? The BMI is 24.5, lost about 10 pounds over the last month. Here's a picture of that person. This person is my mom. And my mom said, honey, do you talk about me at your conferences? I'm like, yes, Mom. She's like, good. So she loves the attention, so here she is. And we were in actually Washington, D.C., lobbying for coverage for diabetes prevention. Okay, so this happens like within this 3-month period. What do you guys think that is? Does the A1C with type 2 diabetes go from 6.2 to 13.9 in 3 months? No. People with type 2, it's like 6.2, 6.5, 6.7. Like it just gradually goes up. This is shocking. So we took her to the provider and we did some more testing. But before I talk about what happened with my mom, I do want to say that the American Diabetes Association, in their standards of care, for the first time this year and last year a little bit, they talked about it, is that recognizing that LADA is a form of diabetes we need to address. And LADA is defined, this is what my mom has, is slow progressive autoimmune diabetes in adults. So it's autoimmune destruction of the pancreas that can occur as in adulthood, but it's slow moving, slow progressing. But they say that this type of diabetes really falls under the type 1 rubric. So they're calling it a slow moving kind of type 1 diabetes. So given that, if my mom has now type 1 diabetes, what does she need to be started on? Insulin, yeah. So this is important because many times we miss LADA. Like my mom could have easily have been called a person with type 2 requiring insulin. But because I met with the doctor and I said, can we draw some autoantibodies? So the doctor goes, oh, what's LADA? Like they didn't know what LADA was because I live in a very rural area. And I go, that's okay, I'm here to help. So I faxed some articles on LADA, just snuck them in there. Anyways, so we do these autoantibodies, and sure enough, my mom came back GAD positive. So GAD positive, her pancreas is under autoimmune attack. So we got her on some basal insulin, and we actually kept her on metformin. So she started metformin along with the basal insulin, because lots of folks with LADA do have some insulin resistance. It's not just pure insulin deprivation, there is some insulin resistance that goes along with it. But the key here is we want to recognize it, we want to identify it, because we want to get that person some basal insulin at the very least early on to protect their remaining beta cells. So if you look at LADA compared to type 2 diabetes, they're more likely to be under the age of 50 when diagnosed, more likely to have acute hyperglycemia like my mom. Her A1C just rocketed up like 6 points in 3 months. They're more likely to be on the leaner side, BMI less than 25, and a history of autoimmune disease. Shortly after my mom was diagnosed with LADA, she was diagnosed with thyroid disease. Her sister has rheumatoid arthritis. So we have a lot of autoimmunity in our family. So it's not just looking at that person and their history of autoimmunity, it's also looking at their family genetics too. It's going to be important. So how many of you recognizing you've seen LADA in your, yeah. It's often under-recognized, and it's the person diagnosed with type 2 diabetes, and we keep trying to use all the oral medications, and their blood glucose levels don't come down, and their BMI is lower, and you just like, it doesn't seem like they have type 2. Maybe let's draw some autoantibodies to verify what kind of diabetes they have. Okay, we have another gal. She's 58 years old. She states she has had type 1 diabetes for 18 years. She quit smoking about a year ago and gained 20 pounds. Her BMI is 25. Okay, so this is based on a true story. I was interviewing this person and listening to her life story. And she told me, well, I take Humalog 18 to 23 units before each meal. Now, when you think about type 1 diabetes, it's an insulin, they don't make insulin, but they're not insulin resistant, usually. But anyways, how's that dose? 18 to 23 units before a meal. How do you feel about that for a person with type 1? Does that seem a little high to you? Yeah, like what would a person normally take, just general? Like 3 to 5, 7 units, something like that. But 18 to 23, so I'm already having some eyebrow raising going on. And then she goes glargine 28 at bedtime. It's a basal insulin. Does that seem like a lot of basal? It's a little bit high for someone with type 1. I'm still kind of curious what's happening. And she throws in metformin. I'm like, what? You're on metformin 3 times a day? And she's like, well, yeah, my doctor started me on metformin because I gained some weight and my blood glucose levels went up. And I wanted to ask you all, what test do you want to do on this gal to see is she really type 1 or type 2? Anybody have an idea what test you'd want to do? Well, those autoantibody tests I was talking about earlier, like the GAD, the TNA, the ICA, these tests will tell us that she really a type 1 or type 2. But this person doesn't have insurance, so I cannot draw any labs on her. I just have to rely on my own clinical, impression. So then I started asking questions because we always go to curiosity to help solve answers. And I go, tell me about your parents. She goes, well, my dad had type 1 diabetes and my mom has type 2 diabetes. And that's when the aha came to me that yes, she started initially with type 1 diabetes, but as she got older, gained some weight, she also manifested the genetics expressed themselves for her type 2 diabetes. So can people have both types of diabetes in the same body? Yeah, they can. Is that fair? No, it's not. But you'll see lots of folks living with type 1 diabetes, if they gain extra weight, become very insulin resistant, and we need to not only address their lack of insulin, but the insulin resistance. So I was at a post-grad ADA conference in 2010, and what they said is that, this is in 2010, so we're still working on this project. 25% of individuals with type 1 also have type 2. And what does the American Diabetes Association say? Well, they don't call it double diabetes, but what the ADA, and this is the first year they've even recognized it in the standards of care, it may be appropriate to recognize a person with type 1 and features classically associated with type 2. So to recognize those folks, they have insulin resistance, extra weight, other metabolic abnormalities. And then they also say for people living with type 1 and this type 2 manifestation, that maybe we can use the GLP-1s or SGLT2s for potential weight and other cardiometabolic benefits. Okay, so this is interesting. So I'm working with a person with type 1. They gain some weight. They have a genetic history of type 2, so they're expressing both types of diabetes. Yes, we absolutely keep them on insulin, but now their research is moving toward adding a GLP-1 to people living with type 1 or adding an SGLT2. Now, this is all not FDA approved. So what I'm saying, it's not approved by the FDA. But as clinicians and endocrinologists are working on this, they're recognizing that there's benefits from adding that GLP-1. And right now in the FDA, the American Diabetes Association is rallying to get GLP-1s approved for treatment of people with type 1 diabetes because the benefit is so widely recognized. Okay, interesting. How many of you have seen a person with both types of diabetes now that you're thinking about it? Yeah. We don't call it double diabetes. We call it type 1 with manifestations of type 2. That's the fancy name. Okay. Now let's talk about another type of diabetes. This is diabetes type 3C or pancreatogenic. Now, we know that the pancreas, it's a beautiful organ, often underappreciated. It makes insulin and glucagon, so those are its endocrine functions, but it also has an exocrine function. It helps make digestive enzymes. So when a person has diabetes type 3C, this means functional loss of insulin secretion in the context of exocrine pancreatic dysfunction. What does that mean? It means the digestive enzymes from the pancreas destroy the insulin-producing cells of the pancreas. So when would this happen? Well, I just want to say one more thing before I answer that question. So about 5 to 10% of diabetes, this type of diabetes, 3C, constitutes about 5 to 10% of diabetes, but it's often misdiagnosed as type 2. Now, the importance of diagnosing this correctly is because a person with this type 3C might be lacking those exocrine digestive enzymes, and we need to replace those. So if a person you're working with says, I have fatty stools, and they have diabetes, they may not only be lacking the insulin, but also those digestive enzymes, and we have treatment for that. So what are some reasons that people get diabetes type 3C? Well, pancreatitis is the most common, 70% of the time. I had a colleague who was in a car crash, and she got, pancreatitis and inflammation. Their pancreas never really recovered from that. Cystic fibrosis and hemochromatosis. So there's other conditions that can impact the health of the exocrine function of the pancreas, leading to damage of the endocrine function. But I do want to talk about pancreatitis for a minute, because we know with the GLPs and the GLP-GIP combos that we have a warning for pancreatitis. But it doesn't seem like there's a causal relationship. We've been tracking this for a while now. But I do want to say that people with diabetes have 2 times the risk of acute pancreatitis. So a person with diabetes has dysfunction of their pancreas, they're more likely to get pancreatitis. And after an episode of pancreatitis, 1/3 of people, so if I don't have diabetes and I get pancreatitis, 1/3 of people will move on to get prediabetes or diabetes. So a person who gets pancreatitis has a much higher risk of getting diabetes in the future. So, pancreatitis can be caused by a lot of different things, but you can see the digestive enzymes of the pancreas move through that common bile duct to the duodenum. But if there's bile stones in the common bile duct, that enzymes can't get through, so they back up in the pancreas and cause destruction of the structure of the pancreas. So those enzymes, when people have pancreatitis, can actually dissolve the pancreas and the beta cell producing function. What can cause this? Well, HIV meds. So we know that people on medications for HIV can have destruction of their pancreas, excessive alcohol ingestion, gallstones, elevated triglycerides. That's why we're always looking at triglycerides level, cancer, injury, and other. Have you worked with somebody, now that you're thinking about it, that had maybe type 3C diabetes and didn't know it? Yeah. We want to keep an eye out for that. I always ask people about their urine and their stool. And I'm like, what color is your urine? What color is your stool? Because it's such an important marker of if things are going wrong, especially in the digestive system. So you want to check that out. But I do have a little anger around this slide that regardless of the cause, hyperglycemia needs to be treated. Sometimes I would hear, like, if a person was on steroids and their blood glucose was elevated, well, of course their blood glucose is elevated, they're on steroids. But the thing is, when the body is exposed to high levels of glucose over time, we all know it can cause vessel damage, and people just don't feel good when their blood glucose levels are high. They just don't have that energy that they're used to. Okay, so now we're on to diabetes type 3. So we talked about 3C, but what is diabetes type 3? Well, it's the link between insulin resistance and neurodegeneration. And I really want to share some shocking statistics with you in a second. Type 3 diabetes is also a term linking Alzheimer's disease to insulin resistance in the brain. So dementia and Alzheimer's belong in this category. It's not an official diagnostic category. There is no type 3 diabetes recognized in the American Diabetes Association standards of care. And it's still an emerging field with lots of studies happening. But it suggests that Alzheimer's may be a form of brain-specific diabetes. Wow, this is so interesting. So here's my shocking statistic for you. Type 2 diabetes increases risk of Alzheimer's by 60 to 80%. That's shocking. So if I have type 2 diabetes, my risk of getting Alzheimer's is dramatically increased. And I'm sure you've worked with people living with type 2 diabetes who have some vascular dementia also, and that's manifested in different ways. I had a gentleman I was working with for many years, and we had him on a very simple strategy of 70-30 insulin twice a day. And he would take, I had to make the dose so simple, 30 units in the morning, 30 units before dinner, just because he had such a hard time remembering all this because he had some vascular dementia. So what happened is he came to our support group one day, And he was kind of out of it. I'm like, Ray, are you okay? And he goes, well, I ran out of insulin. I'm like, oh, when did you run out of insulin? He goes, I don't remember, because he had vascular dementia. So I pulled out my meter, I checked his blood glucose, it was 450. 450 right there. And so one of the support group members says, I'll go to the pharmacy and pick up his insulin. I'm like, great. So they got in their car, got the insulin, brought it back, and we started getting him back on treatment. But I realized because of his dementia and his inability to remember his insulin, that he was forgetting to take it, making his vascular dementia even worse. So we set up a system where he would get phone calls every day to remind him to take his insulin, and that really helped a lot. And that's another thing that we can do is recognize when people are not able to remember or keep track of their medications or their insulin or they need support at home. We can call in resources to help them. So why do people with type 2 diabetes have such a higher risk of getting Alzheimer's? Well, it turns out that insulin doesn't necessarily help with glucose regulation in the brain, but it is a neuromodulator. It helps with the transfer of information. And people with type 2 diabetes have insulin resistance in the brain. So insulin is crucial for clearing these amyloid beta plaques. And have you heard about the amyloid beta plaques and the tau tangles that happen in the brain of people with Alzheimer's disease? They actually are these neurofibrillary defects that stop the neurotransmission of information inside the brain. And that's why people have a hard time remembering, learning new things, and really struggling with just day-to-day activities. So insulin resistance contributes to cognitive decline. But the other thing I want to look at is our gut. So what does our gut have to do with, Alzheimer's? Actually a lot. Because if you look on the left side of the slide where it says the mucus layer for control patients, you can see this is a side view of your intestine, and the mucus layer is nice and healthy. As it turns out, this mucus layer is super important because it prevents bacteria from entering our circulation from our intestine. But if you look on the right side, it says dysglycemic patient. The mucus layer is a lot thinner, so bacteria are more able to leave the intestine and travel to the brain and the body and cause more inflammation. There's actually a specific bacteria, the Akkermansia mucin-phyla. Have y'all heard of Akkermansia mucin-phyla? Mucin-phyla means I love mucus, basically. So it helps keep this mucus lining really strong. And metformin actually is very beneficial to Akkermansia mucin-phyla. So people on metformin have more robust microbiota. But what about the brain, Beverly? Okay, getting to that. So y'all know the vagus nerve innervates the intestine, and the vagus nerve is like a direct elevator up to the brain. So if there's a lot of inflammation in the intestines, y'all know that. When your intestines aren't feeling right, no part of you feels right. If you have diarrhea, constipation, indigestion, it affects your whole being. And so anyways, people with Alzheimer's tend to have more inflammation in their digestive tract. And this seems to also increase the risk of inflammation in the brain and these neurofibrillary tangles. So what can we do about this? Well, gosh, y'all, I want to say, I can't say enough about healthy eating. Where's the dietitians in the house? Dietitians, we love you. So seeing a dietitian can drop your A1C 0.3 to 2%. I mean, dietitians are wildly effective. Their interventions help people live effectively with diabetes and figure out ways to eat that matches what's important to them. But anyway, so Mediterranean diet, setting them to a dietitian, optimizing glucose and blood pressure, and we're working on intranasal insulin. If we get insulin up to the brain through inhalation, that seems to also help with the insulin resistance, and then the GLP-1 agonists, and improve nutrition and gut health. So we want to support cognitive function. We want to recognize people who are struggling with cognitive function and make sure they have the support they need to successfully manage their diabetes and keep blood glucose close to target range. Well, in the last 5 minutes, I'm going to talk about type 5 diabetes. Have y'all heard about this? All right, I was listening to NPR the other day, and a physician in the 1950s was living in Jamaica. He moved from England to Jamaica, and he was recognizing that a lot of the kids were coming to his clinic, and they had this diabetes. The kids were underweight, but he would give them insulin therapy, and the insulin therapy would cause their blood glucose to go way too low. So they didn't really seem like type 1 diabetes. It seemed different than that. This was in 1950, you all, and it took till 2024 to recognize type 5 diabetes. He kept trying to write papers talking about this. He called it type J. But anyways, the International Diabetes Federation finally recognized this in 2024. Now, what is this diabetes? Well, it's from chronic malnutrition. If the child, especially in utero, doesn't have enough nutrition, as they're growing up, they don't have enough nutrition, the pancreas doesn't develop right, and the pancreas cannot make enough insulin to sustain the blood glucose. They usually don't show up in ketoacidosis. That's why it's so confounding. And if you draw their antibodies are negative. So it's severe beta cell dysfunction from malnutrition, impaired insulin secretion. They may come with hyperglycemia. Ketosis can happen, especially starvation ketosis if they're really undernourished. And there is some genetics. So it happens in adolescents, young adults, history of prolonged malnutrition, thin body habitus with muscle wasting. And here's the thing, what is the treatment? It doesn't say insulin here. It says high protein, low carb diet, micronutrient supplementation, and careful monitoring. If, giving them maybe some basal insulin initially, but being very cautious about it. And so, we live in a world where people travel and move to different countries. And I was teaching this section in Hawaii. I was there a month ago, and I was talking about this type 5 diabetes, and this gal jumped up. She goes, "Oh my God, we just had a patient in our clinic who came from Somalia, was undernourished most of his life, and we thought he had type 1 diabetes. We were giving him insulin. His blood glucose was crashing so low that he was getting severe hypoglycemia." And she goes, "I think he's got type 5 diabetes." So we will encounter these unique types of diabetes in our clinical practice. Having this information in the back of our mind when when the unicorn comes to the clinic and we're not quite sure what's going on can really help us provide best care and recognize what kind of diabetes this individual has. So thank you so much for this opportunity to speak to all of you. It's been so great hanging out here in Alaska, and I want to thank the organizers for a wonderful, wonderful conference. And I guess I have a minute for a question.
Yeah, thank you, Beverly. Probably a minute for one question.
Yes.
Oh, but I think Beverly will also be here during the break
I
because
will
I
be
saw
here.
more than one hand.
Okay.
But we'll do one.
Okay.
Could you speak to LADA what you would see the C-peptide do?
Mm-hmm.
I just have somebody I think might
be a
need some more
LADA.
workup.
So C-peptide tells us how much endogenous insulin that person is making. And with LADA, they can be a little bit elevated. So when we took my mom's C-peptide, it was low normal. And so it doesn't give us the picture we need. We have to look at the autoantibodies to see, is there an autoimmune attack against the pancreas? It provides information, but it's not the diagnostic thing. Thank you.
All right. Thank you, Beverly.
Thank you, everyone.
Yep, one more round of applause for Beverly.